Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. Why is combined intratumoral immunotherapy and intratumoral ablation so important? I'm Dr. Nathan Goodyear, and of course, I am with Dr. Jason Williams of the Williams Cancer Institute. And Jason, this is a question that we hear routinely and repetitively, because when you look out in the arena of the oncological world, people are looking at ablation more and more and more as a surgical alternative.
Sure.
And immunotherapy.
Yeah.
But when I get this question repetitively, it means, okay, we've got to do a really good job of trying to help patients understand why these two are so important together. Because
Sure.
You and I played football.
Yeah.
Now, you were a kicker.
Yep.
But you understood as a kicker. By the way, he kicked in the pros.
Arena. Yeah.
That's right, arena, but they're still pros. I didn't play. I didn't play. But when you lined up to kick, was it just about you?
No, it's always a team.
Yeah.
Always.
The snapper?
You got,
the holder?
every part's critical.
That's right. And if nobody blocked.
If you don't, anybody messes up and the whole thing is then, so it's, obviously everybody looks at the kicker and thinks their fault potentially, but it's everybody's doing their part.
Yeah. And so for me, I played offensive line and played center. And so there were 5 of us working as a unit. And when we didn't work as a unit, we usually got somebody really hurt bad. And then we got yelled on the sidelines.
Yeah.
But this concept of these working together really fits into that model of a team.
Yeah. Yeah, it is. I mean, so the thing is that ablation gives you tumor killing and certainly we know can give some immune stimulation. We know obviously that pulse electrical field is, one of the more superior techniques for that. But then, adding on the immunotherapies at that time, I mean, makes complete sense because, I mean, you're starting that process and this is where all the immune action is going to happen, right? I mean, the immune cells are going to be there locally. So the drugs that you want to affect the immune cells, the stuff that is right there, right? I mean, that just makes the most sense. And that's where you can get the real action. That's why this works. I mean, I think it's a bad idea thinking that, you're going to put the stuff from the outside. I mean, again, it's like, why would it be coming from some distant source to get to there where it gets very, very little when you can put it right in there? And the thing is that you're already in there with a needle. I mean, it's like, so just add some drugs. I mean, it makes sense. I mean, why wouldn't you? I mean, like, I don't know. It's just, it's easy. And obviously we need other doctors doing it. Unfortunately, the doctors are tied up with what insurance pays for, right? I mean, so, if insurance doesn't, say that they're going to pay for this, then the doctors are not going to do it. I mean, basically they just go where the money is, right? And they do, what's paid for. And that's not the best treatments, but that's what's being done, unfortunately. Now,
you've said something several times, and I don't know if we've actually recorded this on a podcast, but you've talked about, I think it was when we were medical students, and they were, I think, doing a biopsy.
Yeah.
And you asked the either attending or resident, you asked them something that really, I think, has spurned the innovation that has brought Williams Cancer Institute where it is today.
Yeah. So it was actually in our first year of medical school because we were fortunate that they combined giving radiology with anatomy, and that was unique and that was, and which makes complete sense, right? Because I mean, radiology, you need to know anatomy. And so that's why we had an amazing training, I believe. And,
LSU, by the way.
Yeah, LSU. Yeah. Very good. One of the best. And so, and one of the things with the interventional, they had all these different, doctors talking about their parts of radiology. And then one of the lectures, the interventional guy comes in there and said, well, this is what we do in interventional. We're sticking needles in places and all that. I was like, well, wait a minute. Like, okay, this is stuff I saw in the mice. If we inject in the tumors, it worked, and we knew giving it intravenous or orally didn't work. And yet everybody's telling me that was too difficult. right? You couldn't do that. And then these guys are saying, well, they're sticking needles in tumors, they're biopsying, and obviously that's how we make a diagnosis. So I thought, okay, so we can inject a drug. And I asked them that, and they're like, yep, well, I guess we could, right? But nobody's doing it. Nobody thought about it. So,
Well, I think that's just the kind of thinking that you bring to the table, because it seems like an obvious question,
yeah.
but yet nobody had maybe asked it or even thought to consider it.
No, it amazes me because it amazed me for so many years. I kept trying to push people, say we need to be doing this and doing it myself. But then the other doctors were like, oh no, that's crazy to inject things in the tumors. And I don't understand why. Why? I mean, the tumor is the problem. I mean, if you put the drugs in the tumor, that's going to make more sense. And, so yeah, nobody was seeing that way. And now people are starting to see it. I mean, it's been a long time and it's funny. And in a few years, everybody's going to look and say, well, it's obvious. And I think if people think about it now, and I think patients are looking, are like, well, yeah, it makes complete sense. I mean, that's, but, I don't know, still trying to convince the doctors, and the doctors, have been trained and ingrained with, what they, know and how to treat cancer. And so it's really hard to get them to see that there's another way, so, but
it's like we're telling them that the world's actually round. It's not
that's
flat.
correct. Yeah. So
what I want to do is kind of go through a series of questions that really highlight and support the concept of why the combination of the intratumoral ablation and immunotherapy is so important. So the first one is precision.
Yeah.
What we've had in medicine, Jason, the last, 50, 75 years is kind of the one size fits all approach.
Yeah.
It's protocol driven. But what we're doing at Williams Cancer Institute, it's really precise. It's precision. When I say it's the right treatment for the right patient, the right combination at the right time.
That's correct.
And so I think there's no better imagery of precise than going right to the tumor.
Certainly going right to the tumor. And then when you take that tumor and you analyze it and you look, okay, what are the genetics of it? What are, what's the immunological aspects of it? Because it'd be different for different patients. So whatever data we can gather from, the patient, and then use drugs that are appropriate. Because for certain patients, maybe they have a KRAS mutation, or maybe we need to be using KRAS inhibitor. Right. Other patients don't have that. They don't need that. Other patients have different things. Also, there's some of these genes, like when they look at genetic testing, you do, Guardian Foundation, typical stuff like that. They're looking to see, well, do we have a drug that blocks that or inhibits that mutation? And there's a few that are available, but, and then they get all this other genetic information as well. And some of those are things that give us prognostic factors, well, there could be certain genes where if they have, genes that are in DNA repair, that if that, and there's the typical mismatch repair that everybody talks about, but then there's other DNA repair genes. And then the other thing is, of course, you get a feel for the tumor, because, okay, if they have a P53 mutation, you get an understanding what this tumor is like, what it may be doing, how you could target it. Having all this data and then specifically doing for that patient. Yeah. That's how we do it.
So what you're doing is, this is not protocol driven. Of course, everything has to have a plan, and then you have to pivot from that plan, but there's a foundation of science. Right. And then you're in a way, you're acting as an artist, creatively applying this for the individual tumor.
That's right. I mean, we have a base that we say, this works really well for most people. And then we look at okay, what are the other little things that we could add here and there to make it a little better? It's kind of like, being from Louisiana, it's we have, our gumbo, and, we got all the base stuff, but then you got the little extra seasoning you could add to it here and there.
Everybody, so we got the roux,
and everybody's got their little stuff.
Little Tabasco.
They might add a little bit of this, a little bit of that, make it a little different, and make theirs different from the others. And that's kind of what we do. I mean, when we treat this, we're using lots of drugs. I mean, it's like a gumbo. It's like, a mix of lots of things. Right?
It's like gumbo.
Yeah. I mean, I think, being from Louisiana, it was our nature to feel that's okay. That, you can just throw a bunch of stuff in there, and that's good. And, the more stuff you throw in, the better it is. And that's kind of kind of what we find in these cancer treatments. The more things we throw into it, the better it works. And, obviously balance out, look for, if something's going to cause a side effect, what, there's some of those issues, but for the most part, we have a regimen that we know works well that has, relatively minimal side effects. The big issue is always, overactivation of the immune system. That's your, concern.
So, and then the next question is what form of ablation? Because there really is a growing, tech industry around ablative therapies. Yeah. And so, and you've been with the ablation movement, I think, for quite some time. And so you've seen a lot of them, a lot of the ones that are available to patients to this day, but you've really kind of landed, and the Williams Cancer Institute, we've landed on pulse electric field therapy. Yeah. A lot of times the doctors, and I see several other guys that do ablation, and they get their loyalty where they use the system and then they're like married to that. I'm not that way. I mean, I just look and see what's best, some of it's because these doctors have financial interest in like a particular company. So it makes them want to make that technology better. Whereas I've always kept out of that. I don't have a financial interest in any particular technology. I like to just use whatever's best, and whatever's best. And so, clearly, radio frequency, microwave, I mean, all that type of stuff has, been around and out there. Cryoablation, and since cryo still has its role in certain cases, but pulse electrical field, I mean, this ablative technology from an immune standpoint seems to be superior, and I can't really, it's clearly the best, and I can't even see a reason like why I could argue that any of the others you would use, right? They're so distant. Yeah, there was a murine breast cancer model, and I found this really interesting. PEF, which is pulse electric field therapy, it's nanopulses of high voltage energy. This is a quote from this article: elicited distinct immunomodulatory effects with clear differences in serum and tumor cytokine profiles compared to radiofrequency ablation. Get this. Yeah. There was intratumoral downregulation of vascular endothelial growth factor, hypoxia-inducible factor 1 alpha, c-MET, interleukin 10, Ki67, tumor necrosis factor alpha. But getting into the immune function, PEF increased innate immune activation, enhanced recruitment of dendritic cells, basically M1 macrophage polarization, and increased, it reduced M2 macrophage polarization and actually suppressed myeloid-derived suppressing cells. So the type of ablative technique was in and of itself a therapeutic against the cancer, but also a modulator of the immune system. Yeah, it's like a bonus immunotherapy. I think we do it, and we're just doing it to kill a little bit of cancer. And again, that's the one big concept that messes up all the other doctors with ablation is that, they want to go in and ablate the entire thing, and that will actually not stimulate the immune response. And pulse field is smaller and a little harder if you want to try to ablate the entire tumor, which is a good thing. I mean, making it harder to ablate the tumor is why it's more immune stimulating. These doctors, they try to because they try to ablate the whole thing. I mean, and as much as you tell them this is not the right thing to do, they just don't see it. They just have in their mind, like, no, this is. Well, it's like a surgical alternative. Cut it out. Yeah. No, ablate it all. Yeah. And so we know it's not the right thing to do. And it's interesting that, the pulse electric field has such a superiority in all the things that it does that are, immune stimulating. I think, obviously, other stuff that people might compare to like NanoKnife, IRE, we know, cause, one of my partners, he, developed NanoKnife and he did the studies. Yeah. Touch on that because a lot of patients are seeing and hearing NanoKnife, which is that's really a brand name of IRE, right? Irreversible electroporation. So, this was technology that definitely kills cancer. And it was nice that you could kill cancer in certain areas that were delicate because it didn't mess up other structures. So there was, looking at a lot for the pancreas and, it's definitely, was good for that. I mean, pulse field does that and more. So it's better. So that, that really, it's just obsolete. I mean, there's no real reason to use it, but it's still out there. So people are doing it. And, but the pulse electric field is superior to that. But some people might confuse it, and so but it's clearly different. The other that's coming up a lot, histotripsy. Histotripsy is now getting really popular.
And now I will say histotripsy has some good immune stimulating properties. So definitely an advantage to that. But I don't know if it's good as pulse field. I mean, I think it's going to be inferior, but let's just say even it's not. The difference is pulse field, we are putting a needle in there so we can inject medications. Histotripsy, they do it with the ultrasound probe and they don't put it, there's not a needle in there.
Right.
The other thing is that because of the nature of how you need to keep the lesion very stable, you have to put your patient under general anesthesia, which is very immune suppressing.
Yep.
So you're kind of a negative trade-off there. It's more dangerous, right? I mean, though you're not, sounds great, right? It sounds like, oh, well, it's not invasive. We're not cutting open. Yeah, that's great. But it's more dangerous.
Well, I think, it's anytime you put something down somebody's throat and you have to breathe for them, I mean, that raises the level of risk.
Yeah.
But then also you said the general anesthesia, those are all immunosuppressive.
Yeah.
And when you're trying to activate the immune system and yet you're doing that, because we've talked about Tylenol, we've talked about opiates, and yet general anesthesia will do the same thing.
It will, right? There's certain anesthesia agents, we know that, when you look at anesthesia, propofol seems to be okay. That's what we generally use.
Right. We just do sedation, right? We don't.
Right. Yeah. So we use what would be conscious sedation. The patient is asleep, but they don't need to be, they can breathe themselves.
Right.
So, so they don't feel anything. They don't even know. We do the procedure. They don't know anything happened. It's just as good as like any other anesthesia, but it's much safer.
Right.
And propofol seems to have some pretty good properties. I think it has even some anti-cancer properties. So it's beneficial.
That's the one that they tell you to count down to 10 from 10. And I remember when I got on the operating table and I was laying there and I was looking up and I saw the white bag. It's white. Yeah. And they was like, oh, there it is, 10, 9. And then I woke up.
Yeah.
It was like, wow.
I've never had it.
It's weird.
But it's interesting. It's very lipophilic, and that's why it's it's a drug. Well, it's purely intravenous. Doesn't have any other forms that you can give it to patients in, as compared to like ketamine, which is another anesthetic that is anti-cancer, but you do have multiple forms of that. And so, ketamine is just, challenging because of some of the hallucinogenic properties that it gives some people. So, it makes it a little difficult. It has great factors because it does inhibit TGF-beta. It can be a good anesthetic. It can be good for pain. It can do those things. But the people have to be cautious just from the hallucination standpoint. They can send people in a weird way that they don't like.
Yeah. And we don't want patients tripping out on the operating room.
Yeah. We used it a few times and every now and then we still do in patients, but like the patients and, they're in the room and they're like, seeing things and it's just, problematic. So it's I don't know. This is dosing. If you get the dosing right on it, then you don't have those issues. But yeah, a lot of times the dose that is used for those, the patients have various hallucinations.
Now you kind of touched on this just a second ago, but ablation implies, okay, if we're doing pulse electric field therapy or just cryo or any other ablative technique, it's that the sole intent there is to destroy the tumor.
Yeah.
But you mentioned, immunotherapy, activating the immune system, because I was talking through that study where it was talking about the modulating effect of the immune system. So then let me pose a question to you, Jason. Is the intent and purpose of PEF to ablate the tumor or activate the immune system?
Activate the immune system. It is essentially just another immunotherapy agent that you're injecting into it. And, and can you achieve an immune response without it? Yeah. You don't have to have it. It's just another agent. I can achieve immune responses with various combinations of immunotherapy, throw one in or out there. There's lots of options. That's just another one. And it just doesn't seem to have negative to it. So, when we use it, occasionally if we're unsure, then we just go injection alone and we can still get there. We'll still be able to do it. But yeah, it's just nice. It's a bonus. Unfortunately, it's a little more expensive. They charge for it like it's an immunotherapy.
Yeah, expensive.
The cost of the needle.
So when you hear ablation, when you hear PEF, and you see on the website of Williams Cancer Institute on our social media accounts, think immunotherapy, because that's really the intent and the purpose of it.
Yeah. Yeah.
Now, here was something. It was coming from a 2024 article, and they were saying that the partial tumor ablation, so not total, can trigger a stronger immune response compared to complete tumor ablation because of the presence and preservation of tumor neoantigens. And you've talked about that a lot, Jason, how if we want to activate the immune system, we don't want to destroy it all.
Yeah.
We by intention want to destroy only part of it. Yeah. And that's a concept that's foreign to doctors and I think a lot of patients too.
Yeah, the thing is that, what I observed originally, and I mean, I knew this for a long time. I mean, I knew it before any of these people were publishing these articles. I mean, like we were seeing it, but I couldn't really prove it. I mean, it's nice. I'm glad, they publish and our with work at Case Western, we did as well. But, we knew that was kind of going on. I mean, you just see it. You saw cases where, okay, you ablate part of the tumor. Those patients do really well. You ablate the whole thing too. Patients don't do well. And yet the standard of care, if you're getting ablation, anywhere in the world, is that they try to ablate the entire tumor. And we try to tell people that's not the right thing to do. And yet, I don't know. Nobody's listening. So,
well, check out the show notes because the evidence will be there and you can tell your doctor that they need to ablate part of it. And if they want to learn how to do that, they can always reach out to the Williams Cancer Institute.
because it's the other thing is that, for the doctors, it's ablating part of it, but it's also what part of the tumor do you ablate? Because the tumor actually can be very heterogeneous. And, people just look at it and say, well, it's a tumor and measures 5 centimeters. They don't tell you. But when you look at it, there's different stuff going on in there. And even, you see the PET scan, see the other, whatever scan you see, you can see that the heterogeneous of the tumor where it's, got different areas. And we know that, there are certain areas that we want to target. There are certain areas that are resistant. Ultrasound does a really good job of showing us this more so than, CT, MRI. I mean, PET gives us a part as well, but it usually matches with the ultrasound. So, these areas that are, when you're scanning, that are really dark, because the ultrasound, obviously is reflection of sound waves. Right. And so, when you have like, these areas that are, we call them hypoechoic, are really, really dark. Those are the areas in the tumor, and you'll see it where some areas are lighter, some areas are darker. The whole tumor may look grayish or dark, but then there can be these areas that are darker.
Does that correlate with hypoxic areas?
It does. Generally, it seems to be hypoxic. Yeah. There's some that, some might be fibrotic as well, but then it's like they go together, right? And you have fibrosis and hypoxia.
Yeah, because it's the hypoxic areas that are really driving the immunomodulatory effects that's favoring the cancer, the oncogenic metabolism. I mean, it's in many ways driving a lot of the show.
That's why, that sort of, it's been sort of determined that these hypoxic regions are almost like the command centers. I mean, they're the stuff that's controlling everything. And if you knock them out, that sometimes the whole thing just goes down with it, right? I mean, it's surprising. You would think that you have to go hit all the areas, but just knocking out the hypoxic regions of tumors sometimes is enough to trigger the whole thing to come down.
Just let it collapse. So this is really interesting because there's actually been studies that have looked at ablation with immunotherapy and ablation without immunotherapy. And it's fascinating because the ablation without immunotherapy triggers a insufficient immune response. Clearly obvious, but when you couple the two together, you get the immune response. But again, I think, and this is the next question, by the way, but it comes down to what's the purpose of the ablation?
Yeah.
Is it to try and destroy it all? A surgical alternative in a true sense of the matter. You're just not cutting it out. You're just destroying it in situ. But the really idea here is activating the immune system and let the immune system do its job.
Yeah. Yeah. I mean, the thing is that, we know that for the ultimate cures for a patient to be cured, the immune system needs to recognize and attack and destroy the cancer. So cancer, obviously is working to control the immune system, and whoever controls the immune system controls the body. And so the cancer will do something to try to take control of it. And so you need to have the immune system know that this cancer doesn't need to be there. It needs to attack and get rid of it. If it has any sympathy for the cancer, well, it's going to let it go, right? Right. That's what happens. And so, that's the key. And that's why like other therapies, chemotherapies and other stuff like that really can't be curative because, you need the immune system to know and eliminate cancer. That is the real key. I mean, it's very hard to kill all the cancer and not have the immune system have known to get in there because cancer will just have little pieces and lurk around and grow again. If the immune system's not on top of it, well, you didn't eliminate it.
Well, and I think that's been the fallacy of the last 100 years. It's been trying to destroy it all.
Yeah.
And in the process, that does great harm and damage to the immune system. And then that actually sets the stage for cancer to spread.
Yeah. That's why, all the therapies are just make no sense. I mean, standard therapies, or other stuff that's not, true immunotherapy. I mean, if you're not, doing stuff that's favorable for the immune system, it's detrimental. And, and a lot of the stuff, and the other parts, like obviously we know the cancer, makes the cells around it older.
Yeah.
And the immunotherapies we know actually make them younger. So we're trying to make that process. We're trying to actually make the cancer younger, not a cancer, versus chemotherapies that make things older. And the idea is that make everything old and die, but it doesn't happen, right? So,
and we've talked about that in terms of, aging of cells and cell senescence, et cetera. Whereas you look at a lot of the conventional therapies out there, surgery, chemo, radiation, where cancer is a disease of the aged cell at the micro level, and you come in with these therapies and it makes them older, that's not a double negative makes a positive. It actually accelerates the process.
Yeah. I mean, it's like you get, these chemos and other stuff like that give a benefit. And there are certain situations where, if you got a bulky disease, you got a patient advanced, you need to knock that down first and then come in with the immunotherapy. That, obviously is reasonable, but otherwise, just killing with the chemotherapy. I mean, it's just, you're just not going to get there.
Really interesting study is, again, check out the show notes. It was 2012. So a little bit ago, they were looking at hepatocellular carcinoma and they were looking at radiofrequency ablation. They were comparing it to surgery and they found that even though radiofrequency ablation is not our favorite ablative technique, in 5 out of 9 patients, it actually induced more of a cytotoxic T lymphocyte response compared to 1 out of 9 in surgery. So surgery created essentially no immune response.
Exactly. Yeah.
And radiofrequency, a heat-based therapy.
Yeah.
And so it did create a little bit more immune response that was obviously clearly inferior to PEF.
Yeah. And there's been studies going back, 20 plus years at least, showing that the ablative technologies were superior to the surgeries, in the same situation, which again, like the ablative technology is so much easier, right, than surgery. I mean, that's so, but that's the direction people should be going. And it obviously, it needs to be pulse field, but still, let's say maybe if patients still don't have that option, well, there's still ways you can try to get benefits. I'm not saying it's the best, but you could try to work it out with other techniques.
Right. And here's the interesting, when talking about the combination, combining intratumoral ablation with intratumoral immunotherapy is superior to ablation alone. But here's the biggest thing, and this is from a 2022 article, leading to more durable systemic immune responses.
Yeah.
Durable.
Yeah.
Sustained.
Yeah.
So with the intratumoral ablation and the intratumoral immunotherapy, people think, well, this is a treatment now.
Right.
But what we're really doing is we're creating a sustained systemic anti-cancer immune response.
Right. Yeah. I mean, I don't know, I just don't understand when patients sometimes have the situation where they're looking like, well, I could do ablation and then just ablation alone, or I could do ablation with immunotherapy. Why would they just choose ablation? That makes no sense. I mean, you could do it.
Well, it comes down to your question in medical school. Why can't we treat that?
Yeah.
You got a needle in it.
most of it again comes down to the financial aspects, because the fact is that, unfortunately, ablation alone, you can sometimes get covered by insurance. I mean, depending on the situation. Whereas you add immunotherapy, that's not covered. And so that's a whole different deal. And so, but, again, well, patients have to decide and try to, see, can they, should they, I mean, if you can do it, you need to try to inject immunotherapy in there.
So then another question is, because when people think about immunotherapy, they're thinking about the systemic delivery.
Yeah.
Which, historically, you look across all solid tumors, the response rate's poor.
Yeah. Yeah.
15, 25%.
Yeah.
Now there are some tremendous success stories that are available from the systemic approach if it's matched to the molecular profiling, but overall it's very poor. But what about systemic immunotherapy versus intratumoral immunotherapy?
Yeah.
What's different about that? What's unique about that from the intratumoral approach versus the systemic?
Yeah. And there's several studies kind of comparing, those head to head and you see that, again, you can use lower dose. Well, obviously one advantage, obviously you lower dose in multiple combinations. That's one thing. But let's just say if you're comparing head to head, like CTLA-4 inhibitor like Yervoy and a PD-1 like Keytruda or Opdivo injected in the tumor versus giving it systemically. I mean, it's so much more effective in the tumor because when you give it systemically, very little of that dose actually makes it to the tumor site.
Yeah, I think we were talking the other day. You said like 4%.
4% is what we believe, and so that's just like very little. So I can take a smaller amount of drug and put it right there, and that's way more than 4%, and so it's more effective. And so the same drugs you can put in there. We've been trying to like get everybody to understand this for a long time, and the pharmaceutical companies are the resistance of this, because they don't want their drugs to be changed from intravenous where you use more to intratumoral where you use less. I mean, when I first went to some of them, I won't name who, but I said, hey, got great news. I can take your drug and I can inject it in the tumor. It works way better. And we're using less drug. And they're like, yeah, don't talk to us anymore.
Yeah.
Like, go away.
Why would you do that?
Yeah. And they're like, don't do this. Like, and then, they actually then started making it hard for us. Like, I mean, they didn't want us to do some of the things. And so,
now, when we talk about intratumoral immunotherapy, people think, okay, I'm thinking of the drugs, like you mentioned PD-1, CTLA-4, et cetera. But honestly, we're injecting other things in that are modulating the immune system. That's not just those drugs.
Yeah, because you get to a lot where patients or the doctor, and I see this all the time. The doctors will the patient's like, oh, I'm going to go get this intratumoral immunotherapy. And I say, well, you don't have PD-1, you don't have PD-L1 in your tumor.
Good point.
You don't have mismatch repair. Yeah. So it's not going to work. Well, that doesn't matter. I mean, well, first thing, those aren't even good markers. So I wouldn't even use that for PD-1. I mean, you can say that, but we're doing way more. I mean, we're using multi combinations. We're hitting multiple checkpoints. I mean, LAG3, B7H3. I mean, got even others that we can do. And then of course we're doing like co-stimulatory molecules. I mean, you've got 4-1BB, OX40. And then you got, the sort of, multi, CD40. Gosh, I mean, it does so much. This is a completely different deal. So none of that even applies. So they're looking at it and saying, well, yeah, that you don't have that, but it's not going to work because this is not the situation. This is a completely different deal. This is a much more effective immunotherapy. And so none of those factors, mismatch repair deficiency, all that type of stuff that they want to, cite as being those are the only patients that respond to immunotherapy is not true.
So again, another mouse model, and you're familiar with the mice because you used to.
Oh yeah.
You tell some great stories about your pre-medical school testing of mice, or even in medical school and beyond.
Yeah, I had some, even had in my laboratory in my own house.
But it was really interesting because they were looking at cryoablation intratumoral immunotherapy with CpG ODN 16668, which is a TLR9 agonist.
Yeah.
And what they found is that cryoablation alone provided some protection against the tumor rechallenge after ablation. But what they were doing here is they were trying to create a model that looked at metastasis. Mm-hmm. And so they found that when they surgically resected the primary tumor which they treated, the later implants that they implanted into the mice, they didn't respond as well.
Yeah.
So, a lot of people go, wait a second, you mean if you leave the tumor there that was treated, and then you created a mouse model that you implanted a new metastatic site, so thinking distant metastasis, a model, if you left the tumor in place, those distant metastatic sites responded better to the immune activation versus if you surgically removed it, there was a reduced immune response.
Sure.
So again, it comes down to immune system.
Yeah. Yeah. So, you want to maximize and do everything and surgically removing an area. I mean, because it came up a lot, particularly before, breast cancer patients, early stage breast cancer, and we would just cryoablation of their tumor. And then some of the patients would have the option that they could do, lumpectomy after.
Right.
And, well, I say, well, you could. And also I tell them, like, if you do, you need to wait. You need that time period to allow the immune response to happen, because usually we're trying to do this in an immune stimulating way. And so, because if you did that and then you immediately surgically cut it out, you actually remove all of that immune stimulation that's going on there, and it doesn't get a chance to spread in the body. And then their risk of getting future metastasis is not reduced.
And what they found is that when they looked at the metastatic model, of course, again, what they did is they had the primary tumor, they treated it, and then they came in and they implanted, again, secondary metastatic sites. In those that they left the tumors in place, there was a 40% regression of those implanted metastatic models. But those that did not, so they removed the tumor, no response.
Yeah.
So it's complete. Yeah. So now clearly surgery to reduce tumor burden can be advantageous sometimes. But we don't want to say there's not a situation where it can't be.
Yeah, there may be certain situations. I mean, again, it's like we're not demonizing completely that, chemo, surgery, radiation, it has zero use. It has use.
Just a little bit.
But it has a little bit, right? It's limited, right? It's being way overused. I mean, that's unfortunate that, and that's why they're not seeing this other stuff. They're so fixated on these things that are not working as well, and they're not seeing these other options. But yeah, but in the future, I think obviously we want to have it where patients don't have to have surgery, hopefully. And, hopefully you catch the patients early enough where it's not a situation that they need surgery. If you do that, you can get under control. It's just when things are more advanced, well, then, you get patient with a colon cancer and they're obstructed. Okay. Well, they got to have surgery. There's no option there. I mean, you're not going to fix that and make the person better.
But I tell people all the time, as you walk outside, you fall, break a hip.
Yeah.
You got to surgically repair that.
Yeah. There's, it's always appropriate in certain situations.
So what about another question is the timing? And I get surprised because, our patients are quite intelligent.
Yeah.
And I've had some questions from patients about, well, is it better if we do them together, or if we get IV systemic immunotherapy later?
Yeah.
Or I've even seen it called the in one go, which is kind of what we do. Yeah. So what do you think, Jason? Because I think you've been doing this longer than anybody else in the world.
Yeah.
What's the best strategy to bring the immunotherapies in combination together?
Yeah.
For the activation of the immune system intratumorally?
Yeah. I mean, one of the things, of course, is looked at, Martin Denbrock. He did a bunch of studies looking at spatially, like doing, ablation and immunotherapy. Like you do ablation and did the immunotherapy. Well, did immunotherapy first, alone, and then ablation, and then ablation and with immunotherapy, and ablation and immunotherapy after, even still injecting in the tumor. So we understand, 1 day, 3 days. I mean, but it was always at the same time was superior, from what we saw. So, and it makes more sense. I mean, you're going ahead and you're ablating. I mean, you'd like to go ahead and have that immunotherapy on board right at that moment. And so,
don't want to waste time. Don't want to waste time.
Yeah.
And then we've talked about this too, the chronicity, the circadian rhythm.
Yeah.
And we've talked about this elsewhere. So I encourage you to check out those podcasts where we talk about the circadian rhythm of the immune system and immunotherapy, the timing of it. Because again, if you give systemic chemotherapy in the afternoon, those patients have lower overall survival.
Yeah.
But here we're talking about the timing as it relates to a circadian rhythm. Touch on that just really quick.
Yeah. So we know that, the immune system sort of works in a cycle. And so it will start, potentially attacking cancer in a phase. And then it will then switch more to like either not attacking or more regulatory, where it could be protecting cancer. So it's like the attacking cancer part works. And we know that based on the studies that were done, that the cycle runs about 8 days, and it's about 4 days of attacking and then 4 days of regulatory. And it goes back and forth like that. And so when you give immunotherapies, if you give it the wrong time, you give it where the more regulatory, you may boost those cells, right? And those are protecting cancer. And that's going to not work as well.
So what you're saying is immune stimulation is not always good.
Right. I mean, particularly depending on the agents and what you're doing. I mean, there can be a certain, the time, and particularly, I mean, obviously we know some of the cytokines, interleukin 2 being the great example on that you give at the wrong time. And yeah, it goes, that's why.
Because if you're increasing myeloid-derived suppressing cells, T-regulating cells, that actually, that's immunostimulating, but it's immunosuppressing.
Yeah. Yeah. That's, when we do immunotherapy mix where we're not quite affecting this other thing, so we're able to get around a little bit on the timing.
Mm-hmm.
Also our drugs sort of linger around, so they can kind of, still be there, as the cycle changes and start working as you need it. They're a little bit different, but yeah, it's definitely more like some of the cytokine stuff. You have to be cautious with that, cautious on the timing. We know that, you can try to measure this with a high sensitivity C-reactive protein was kind of the way to do it. But yeah, unfortunately standard practice doesn't do any of those things, but those would be all nice things to do.
And then, another question is, you mean you're injecting more than one thing as an immunotherapy?
Things, yeah. So we do, we throw a lot of stuff at it. And so, there's various things. I mean, and there's various like phasing of stuff. I mean, so one, you attack a cancer and you need to recruit immune cells to it. So let's say it's a brand new cancer. I mean, like a cancer that you haven't hit with immunotherapy, and you're going to assume, I mean, you kind of know, but you're going to assume that the immune cells are probably not there or not enough. And so you need to use heavier the drugs that kind of recruit those, the drugs that are saying, hey, here's a problem. You need to come here. And so there's a certain class of drugs that do that affect a little more of the innate immune response. Obviously, toll-like receptor agonists are certainly a big part of that.
Yeah.
And then there's the sort of the transition phase. Well, now you got the cells there, but they could come in and say, well, okay, now there's nothing to see here. Let's go away. You need to give them that stimulus and saying, yeah, you're here. You need to like attack this. And so that's kind of how we do this sort of like in the phases. So I adjust the immunotherapies on that and start changing and using more of the agents that will then, say, okay, yeah, keep attacking. And then you've got the sort of other phase of like, well, now the immune system is attacking, but the cancer then can start shutting it off by the checkpoints. And so then as you get further in the therapy, you're going to start heavy weighting the checkpoint therapies. I mean, so, you can start backing down on some of the other agents. And then, now there's sometimes, I mean, you may want to use all of them. You may want to just adjust the levels, right? I mean, that's kind of what we do. And I mean, we don't just follow protocol. Yeah, I know. And that's what makes it sort of complicated. And that's why it's really hard for people to duplicate this. I mean, we know in our studies and trying to get this out to other doctors, we're just trying to make it in a simple format and make it where, okay, this is what you do and you just do this all the time. And that works decent for most people. It's not the best, but it's good. As well, I developed this, cancer care AI. I don't know if you've seen that. Yeah. So the concept behind that was that the cancer care AI, it'd have all the data in there, the DNA and RNA and all the information, and it would tell you what immunotherapies you should be using. So, and it would, and in the future, we'll have this where that will be connected to a system that's robotic. Yeah. The robot will have the needles and stuff will be loaded like an inkjet printer, and it'll have all the different drugs. And then it'll know exactly where to go. It'll know where to go. And then the AI will know the drug combination, and it will, do it all like the different mix. And so that's kind of the future of what we see. I mean, we haven't made it, but we're designing on paper. So basically what you're saying is where we are right now in the Williams Cancer, you brought the future to today. Yeah. Yeah. But you're already working on the future of the future and the future of that. Yeah. Yeah. We're working on stuff that, is going to be, like it's going to look like from another planet. I mean, it's not, with, robots doing the procedures, because again, the issue is that, we can do it. Lots of doctors can do it, but there's limitations and also want to make it easy where like, there's, that just access for more people. And so if we can do it robotically, then that's going to make it easier where the doctor can just be there monitoring and let the robot do it. And then of course the software, the AI, which will interlink with the robot, knows the drug combinations, because it is too complex for most doctors to know and understand. And so that they just don't have to think. They just do it.
I think you said it correct. They just don't have to think.
Yeah.
And basically what you're kind of doing, I had this picture of a Picasso or Rembrandt, and that's what we're doing. And then, other doctors or other practitioners out there, they're just doing stick figures.
Yeah.
It's it's the protocol versus the artistry of it all applied.
Yeah. I know it's important, but that's why we're trying to democratize this to get it to everybody. We want everybody to benefit. I mean, we're not wanting to be the only place that does this. I mean, that's why we do. So we hope that doctors are listening to us talking right now and are doing this, and we want them to do it. It's not a competition. It's to save lives. I mean,
I don't think anybody's short on patients with cancer, unfortunately.
No, and so, in my opinion, what happens is, I mean, I see there's people suffering.
Yeah.
I mean, and it really bothers me to see that, like, people are being maimed and they're dying, and we could fix it. I mean, I know how to fix it if people will listen to me, right? If they'll do what we say, that we could fix this, and we just got to get them to listen.
Yeah. And, what's really interesting to me is when you do the intratumoral ablation, intratumoral immunotherapy, it's actually, you talked about innate immunity, and then there's the adaptive immunity.
Yeah.
And then there's this Th1, Th2.
Yeah.
And it's really interesting when you look at the combination of some of those immune checkpoints plus intratumoral ablation, you trigger a innate, but also then a adaptive immunity, but it also shifts the Th2 to Th1.
Yeah. So it's always the immune system always has a counterbalance of, like, so you're going to have the potential attacking, and then you got the regulatory protecting.
Mm-hmm.
So, and then these cells, they all look alike. I mean, that's why, like, you don't know, is that attacking cancer? Is that protecting cancer? Their receptors all look basically the same. It's just the jobs that they do is different.
Right.
And so that's why it's challenging with some of the drugs, because, you may be affecting the regulatory cells and you're helping them, when you wanted to be helping the cancer attacking. And so, but when you can convert the cells to where they're not wanting to, protect the cancer, and they're wanting to be on the side, it's like you got, you're fighting a war, and you got some of the other troops on the other side to join you.
That's right.
That's what happened. And as you do that, that's a really good thing, because your original option is you got to kill them. But if they join you, now you don't have to kill them. Now they help you, and now they work with you. And then the stuff that you give is more beneficial, because now you give the weapons. Before you give the weapons, just go on their side there, and they might be killing you, but now they're working with you. And so it will help you out. And so that's kind of the big key with it. And so, any way that we can convert those regulatory cells from not wanting to protect, wanting to attack, then that's a big advantage.
So basically, from a pro-tumor to an anti-cancer, because
that's right.
People think, well, when you introduce immunotherapies, the cancer waves a white flag and says, I give up, but actually it pushes back.
Yeah, cancer gets really, that's super adaptive. I mean, and like, it's so much stuff that you hit it with, and it tries to get around it. And that's why, your only way is to do just a major onslaught of, like, so many therapies and overwhelm it, so that it doesn't have a chance to adjust, because you leave stuff uncovered. That's why you're never going to get it with, 2-3 therapies. This is not enough.
Or sequential. I mean, it's like cancer goes, oh, here comes surgery. Oh, shoot, they're throwing me a curveball with chemotherapy. Never saw that one coming. Sequential. And it's like, no, cancer is constantly mutating and adapting.
It always figures out kind of a way, until the only way is that, the immune system going against it, because cancer, to survive, needs the help of the immune system, because the immune system is the architect and the constructor of the body, and it controls, like, where the cells go, what they do, and this was the stuff that we saw in some of the cancers where, the immune cells, like particularly when cancer spreads to the bone, the immune cells were going to the bone and prepping the bone and then the cancer came.
Right.
Those immune cells are normal, right? I mean, they're not cancerous, right? But they're working for the cancer. And so so the cancer has control of that part of the immune system, which can decide how it wants to build things in your body. And so that's how the cancer can get into other parts and invade it. It needs the immune system to do it. It doesn't do it just by itself. Very rare that cancer can just go lodge in a place and grow. It has to have the help of the immune system.
Yeah, really interesting. Again, study was looking at 3 treatment arms: cryoablation with ipilimumab. Whoever comes up with the names of these drugs should be tarred and feathered. Just aside, my opinion.
It gets complicated as you get more and more. It's just, I don't know, they're running out of names.
I think they played Scrabble when they were
Yeah.
coming up with the names of these. As you'll get 58 points or something. So 3 treatment arms: cryoablation alone, ipilimumab alone, and then cryoablation with ipilimumab. And they found that, and it was a breast cancer model, but sustained 30 days. The 30-day sustained immune response was only in the combination group.
Yeah.
But it was because they were shifting the Th2 to the Th1, which is what you're talking about, that kind of immune protective regulatory to activating against the tumor, become anti-cancer.
Yeah. Yeah.
So just really, I mean, that's just the evidence to basically back up exactly, what you're saying.
Yeah. Yeah.
And we touched on this a little bit, but, stimulating the immune system at the wrong time or stirring inflammation, that's not always good.
Right. Yeah. Yeah. There's inflammation, there's different types of inflammation. And so there are certain situations where the inflammation may be anti-cancer. There's some inflammation where the immune system is attacking cancer, or there's inflammation that's pro-cancer. And so there's a little bit different. Obviously, I think, somewhat more prostaglandins seem to be more pro-cancer, but yeah, that's definitely, an issue there. And so some patients, get concerned and say, well, if I take an NSAID, an anti-inflammatory drug, is that going to negatively affect my immune response? Well, it actually turns out it seems to help because that's an inflammation that you don't want that affects, versus steroids, which affect inflammation in a different form. Right. And that's negative. And that impacts the immune response and will make the immune cells not want to attack the cancer.
Now, this is a question from me for you, but it's not a question that typically I've heard from patients or yet have. But obviously, clearly the goal and intent here is to activate the immune system. Yet, in the process of ablating and destroying part of the tumor, if you don't create a word you said earlier, co-stimulatory signals, which we inject in there, you actually can stimulate a tolerogenic response.
That's true.
So this is tolerogenic versus immune activating, but you connected that very early on in this conversation tonight about co-stimulatory signals, which we inject in to go with the immune checkpoints and other immunotherapies.
So it's a problem. That's why sometimes like these immunotherapies, like when you do some of these PD-1s, also if it's out of sequence for that person, that really can, negatively affect the immune response because you're trying to tell the immune system to attack, and then it looks and says, okay, I should, but then it doesn't get the full signals to go through with it. And then the immune system remembers that. And then when you try to say, hey, attack this again, it's like, no, I already saw that and I didn't get the signals to go. So it won't even initiate it, right? So now you made it worse. I mean, now you've got it where you got to work a lot harder to try, and that, that's a situation you don't want. I mean, you want to try to, treat it. And that's why sometimes the patients, they don't understand. Like you do one treatment and you're getting that immune system coming in, and you do a second and then you're boosting it, and the patients really get a scan and, the cancer is not smaller because like this, hasn't really had a chance to really affect it. And it's not working. So I'm going to stop. They do that, and it's the worst thing you can do because, you just start a process and you need to finish it out. Yeah. And if you don't do that, and then what happens? They wait, and you have to try to convince them, and they delay it. And then we're in a situation where we kind of started it, and now we let it go, and now it's much harder.
Yeah.
And the patients I understand where they're coming from on it because they're thinking from the chemotherapy aspect, but they don't understand from the immune aspect. That's a process that you're going through it, and you're starting it going. You have to push it along, and you can't expect it to, be finished then. It's like, it's like building a house. you bring the materials out there, and is that you don't expect the house the next day. I mean, you expect that they're going to pour a foundation and, put up the studs and stuff like that. That's the process is going to happen, and so it's the same way with this.
And the final question is, people go, well, why not? Why does just stimulating the immune system, why does it just not attack the tumor? Because some tumors are cold, some tumors are hot. So in some tumor types, we have to actually manipulate a non-immune responsive tumor to become immune responsive.
Sure, yeah.
So there's this cold versus hot debate. And of course, that's where this conversation of ivermectin comes in. But there are other therapeutics that we can use that help to take cold tumors hot. And so this can be a part of the strategy we employ as well.
Yeah. And one of the things you get the immune system attacking the cancer, but and maybe it's going good, and the cancer, immune system's really attacking it, but the cancer's still adapting, right? The cancer's still changing. So you may be starting to get a good response, but you got to keep pushing it a lot of times. And the question is, what is the point of when you push it enough that the immune system by itself can do it without you assisting it? Right. And that's different. I mean, there are certain cancers, one shot. You do one shot and boom. And that's what I think, makes it challenging for some of the patients who their cancers are more difficult and they need, multiple treatments. But they say, well, that person only needed one. Yeah, but that's a different cancer. I mean,
that's right.
Different, it's a different situation. And we know which ones we understand which ones are more likely to respond easily and which ones are going to take longer. And occasionally, it's not always just that cancer type because there's other, things with it. And so you never know. It'll be different for different people.
So basically what we've done in this podcast is go through a series of common questions, maybe misconceptions. And I threw in some extra questions about why we do what we do at the Williams Cancer Institute. There's great intent and purpose, and it's not just a protocol aspect, but it's actually guided by science. Mm-hmm. It's guided by experience, of which I don't think anybody has the experience that you have out there. And it's guided with an intended purpose to empower the immune system to do its freaking job, which is to target the tumor, destroy it locally, and then activate to then transfer that to distant, untreated tumors. Yeah. Create a sustained systemic immune response. And you can only get this at the Williams Cancer Institute. Yeah. So, I mean,
but unfortunately, right?
Unfortunately.
Again, we want other people doing this. We want everybody doing it. We're not trying to keep this to ourselves, but unfortunately, we are the only ones. I mean, there's nobody that does what we do. And I'm sad for that. I mean, I want other people doing it.
And I've gotten to know Jason really well. Of course, we knew each other back in medical school. We've reconnected and got to know him even more. And when he says he's saddened that more doctors don't do this, it's legit.
Yeah.
It's legit. Yeah, I mean, and because none of us are hurting for a shortage of cancer patients, unfortunately.
It's not a money issue. I have plenty of stuff going on. I don't need to make money in this. I can do other stuff. And I will, when we have cancer fully cured, I will do other things. I'll be very happy to do it. Yeah. But it's just trying to help people because, I see the people suffering, I know they're suffering, and I know that there's so many out there that are suffering and I can't get to them. I can't help them. And this is, I'm trying to get it out there, and hopefully, I think eventually it will get there. But it's just unfortunately it's too slow. I mean, all the times I see these famous people dying of cancer. Yeah, I could save them. I could have saved them, but they didn't come to me. They didn't know, and they assume that that these top cancer centers are their best, and they don't know about our stuff. And so, cancer patients they have to do their research and see. I mean, really, really look at it. Don't be just blinded by, well, it's a big name center, right? And thinking they've got to be the best because they're not.
So where can patients or doctors that may be viewing this or listening to this, where can they find out more information about you and the Williams Cancer Institute?
Yeah, obviously we've got WilliamsCancerInstitute.com, and then in my book. My previous book, the Immunotherapy Revolution, I think is still good. It's
still very relevant.
And that's will give people, helpful tips. If there's doctors out there that want to, just so they just want to come visit and see, and we help out. We do have some doctors that do that, some that come in, and there's a few that they're trying, they want to do it. They want to do the stuff. I mean, I've got several, good interventional people that I work with. in the U.S. and they would love to do what we do, but they're stuck. I mean, they do what they can.
Yeah. Which is, they're stuck in a system that limits what they can do.
Yeah.
Which is kind of why we're down here in Cabo.
Yeah, exactly.
If you didn't notice, that's the ocean in the background. So, it's not a bad place to go to become well again.
Cabo's my favorite place. I mean, I live here because I love to live here. I mean, people like thinking like, why would you want to live in Mexico? I mean, it's great here. I mean, I go to the U.S. some, but I prefer to be here.
Yeah. And as always, check out the show notes for this podcast episode, because there you're going to find the evidence that actually guides behind why we do what we do at the Williams Cancer Institute, and honestly guided this discussion. And if you want to go deeper dives, we'll have that information there for you as well. So thank you for joining us on this podcast, and we will see you on the next podcast. And Jason, I hope we get to do many, many more together.
Oh, yeah.
Just like this in this setting, because it's pretty spectacular.
Yeah.
All right, man. Thanks. Thanks for joining us on this episode of the Prescribe Podcast. All references supporting this episode can be found on the prescribe.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.